Hello everybody, a very warm welcome back to Stewarts Soundbites. First of all, I have to apologise because I think my internet's a bit dodgy today, so bear with me. Hopefully it will be all right. So today I've got an absolute treat. I'm so delighted to be joined today by Dr. David Lee. David is the clinical director at Sleep Unlimited, and he's also an author of an amazing book called Teaching the World How to Sleep. And we'll make sure that all of those details are available for you after there you go. Hold up proudly, David, that's it, Teaching the World to Sleep. So all of you probably that are watching will be familiar with Sleep Unlimited and the type of work that they do. And along that vein, we thought today it would be really interesting to talk about this elusive concept of sleep. And all of us, I mean, I'm sure you'll agree, David, none of us get enough sleep, which is not great for us, but has an even bigger impact upon the types of clients that we work with who've sustained catastrophic injuries. So we're going to talk a wee bit today about how sleep becomes corrupted and the problems that David comes across and how we treat those and all really good stuff. So I'm going to dive in. David, if you don't mind, first of all, thank you so much for coming on.
Thanks for inviting me. Nice to see you.
Yeah, you too. It's so good to have you. But I'm going to dive in because we haven't got much time. If anyone has any questions during the course of the webinar, type them in the Q&A box. If we can address them, we will. And if not, we'll come back to you later. So as I touched upon, David, lots of the clients that we work with that have catastrophic injuries suffer with some kind of disrupted sleep. And it'd be interesting to hear from you the most common problems that you come across in your practice. And I wanted to ask you as well, I know I'm shoving two questions into one here, which is cheeky, but do people's sleep problems vary depending upon their injuries or their problems?
Sure. So we know that 50 to 80%, quite a wide bracket of people who've had some sort of brain injury have a problem with their sleep, and that's from a range of different studies with different levels of injury. So probably the more mild end you'd see half, but at the more severe end you'd see more towards the 80%. Obviously you've got damage to the brain and brain healing after an injury, and when we have damage to our brain and we're in that healing process, we need more sleep. So we'll see people who've had stroke, brain injury, as well as another form of brain injury, people with Alzheimer's disease, which is a neurodegenerative condition, of course, but you can analogize that to a kind of brain injury as well, need more sleep when we're recovering. But of course, sleep's then corrupted by the brain injury itself. And it depends where the injuries are in the brain as to which bit of the brain is affected, as to whether or not our sleep's impacted more or less. There's a pre-morbid sleep history. If you were a vulnerable sleeper, if you were an insomniac before an injury, you're more likely to struggle with your sleep afterwards. Or if you're a resilient sleeper before an injury, you're more likely to be in a better place after you sustained an injury. Then you've got loads of psychosocial stuff going on. So we might not be working, we might not have good routines, we're not commuting, we're not being challenged physically and mentally during the day like we were prior to our injury. We're bored, we're sat inside watching daytime TV, kill me now. We're not getting out into the sunshine. We know sunshine is really good for producing melatonin. That helps us sleep. So people can become more isolated indoors under artificial light, bored, anxious, stressed, depressed. Mood issues on the back, and all of those can affect our sleep, along with ongoing litigation process, which can take, I don't know, what's your average, 7 years?
Well, it totally depends on the age of the claimant, the type of the injury, but I mean, you're looking at 3+ years in the majority of cases.
And I mean, I've worked with cases where it's been going on for 14. You're not unfamiliar with those. So we've got a long time to live with ongoing litigation. And then in that process, you've got a tired person because of the injury and all those other things that we've been talking about. And they've got to meet appointments with their physio, their OT, their solicitor, their case manager, their psychologist, as well as try and have a family life and bring up their kids. And that's it. All of that's exhausting as well. So we have to be quite careful. We have to treat in each case on its own merits based on the whole round picture there. because everybody's different with their sleep anyway. But when you put in those extra levels with a brain injury, all the psychosocial stuff, the healing process, where the damage, how severe the damage was, medication side effects, pain, anxiety, depression, you put all of that in on top, we're going to have to then deal with that individual in a number of different ways depending on what their issues are. So
Yeah.
we've done about 450 medical legal assessments with brain injured folk over the last 12-13 years now.
Wow. Yeah.
65% adult, road traffic mostly, or falls, 35% pediatric, mostly birth trauma.
Yeah.
All different.
Yeah.
Everyone's different.
And in that vein, David, I suppose that it's a real kind of MDT effort in that regard, isn't it? You know, because it's, as you say, it affects a kind of a huge spectrum of issues, and it's not just something for one area to be aware of. It's for the whole team to take account of, isn't it? Really.
Absolutely, and the multidisciplinary approach is the only way to go. We can't operate in a siloed way, because my advice is going to conflict maybe with what the OT says, or what the surgeon says, or what the solicitor wants to happen. Or we have to collaborate. That's and when we do that effectively, we see much better results, because we can then get everybody on the same page and help support the client. So I mean, we might do an assessment and provide some recommendations that are then picked up, and the psychologist supports the client with a bunch of stuff that we're recommending, or the physio does, or the OT does, or the case manager, or the family. So we have to work collaboratively in order to be successful.
Yeah. And have you seen cases, David, where someone who has a catastrophic injury and that's resulted in disruptive sleep, have you seen that really, this is probably an obvious question, but have you seen that really negatively impact their program of rehabilitation?
Yeah, absolutely. I mean, there's quite a lot of research. If you're looking at recuperation, rehabilitation in hospital, you know, hospitals really like to discharge people because they get better at home, because they sleep better at home, and they really don't sleep well in hospital. So clinicians want to get people back home as quickly as possible so that they can recuperate, because you never sleep anywhere as well as in your own bed, you know. So sleep's critical to the recuperative process, the rehabilitative process. If you're not sleeping well, you're just not motivated to do your exercises. Your mood is so low, you forget things. If you're sleeping better, you've got more energy, you've got more motivation, your mood's up, you can remember what people are asking you to do. So it's people talk about pillars of health: sleep, nutrition, exercise. And nutrition and exercise get loads of attention, and sleep gets very little, mostly because it's enigmatic, like you said at the start of our chat today. And there's not many people trained in assessing and treating sleep problems. You know, we're quite rare, people like me. There's not many of us around. So sleep gets a little bit forgotten about, but it's not a pillar. It's a foundation stone on which those two, nutrition and exercise, stand. It doesn't matter how good your nutrition is or how good your exercise is. If you're not sleeping well, you're not going to have a good life. So we've got to get that right first, and everything else will build on top of that. And that's true for everybody, but much more so because with people who've had brain injury, because of all those factors and reasons and issues I've just put forward there.
Yeah, of course. I just know everyone watching this webinar is thinking, I need to go to bed earlier, I need to sleep better, I need to turn off all the screens. But we did say, actually, David, that we're going to come back and do a separate session for professionals and looking at their own sleep. But just dragging us back, thinking about for the benefits of people watching this webinar who may be involved in rehab, maybe rehab professionals, can you explain when someone should be referred for a sleep assessment? Is there a perfect time to do that, and how do we identify when sleep problems are severe enough to warrant that intervention?
So yeah, it's a good question, and there's probably no perfect answer to that. I mean, there's certain guidelines that we sort of self-impose on us about, you know, when's the right time to assess someone. So if we're working with children, we wouldn't do it in the school holidays, because their routines would be spun out. So we'd try and measure them whilst they're in their consistent term time routine if they're at school. We wouldn't assess someone if they've just had a medication change, or if they're just about to have, or have just had some surgery. We want them to be stable on their medication, stable with their mood, not having just had some sort of surgical or other intervention in the last month. So that's when we would maybe come in. But in order to identify whether or not someone needs some help, the number one indicator that you're not sleeping properly is that you're tired in the daytime.
Yeah.
So if you're not tired in the daytime, you must be getting enough sleep. So we wouldn't worry about you. But if you are struggling in the daytime, and that can be occupational, psychological, relational, psychosocial, any daytime dysfunction that's related to tiredness, that would then suggest to us, right, we need to now assess your sleep. And then what kind of sleep problem do you have? Is it problems getting to sleep, staying asleep, waking too early in the morning? What lifestyle factors are going in? Is it a chaotic routine? Is it sat in front of the telly all day not doing anything? Is it nicotine, alcohol, recreational, over-the-counter or prescription drug use? Is it pain? Is it anxiety, depression, psychological stuff? That's what we then need to assess in detail to be able to then triage that client into the right level of care. Yeah. With the right health professionals to support that. Yeah. Be it directly from us, or the clinical psychologists on our team, or neuropsychologists on our team, or physiologists. It could be that someone maybe have sleep apnea, where they stop breathing properly at night, which we will screen for that as well, because we know that we have an increased incidence of apnea in people who've had a bump on the head. Brain damage can cause apnea to onset. So that's something. So if we flag that up, then we pass that on to our physiologists who assess and treat apnea. So it's about being holistic. It's about a good formulation for each client individually to work out what they need and when they need it. But it's daytime dysfunction first. We don't really need to worry about that, because the people who come to us, they already know they're tired. That's why they've come to us. So we already know we're picking problem up already. Yeah. We now have to screen for where is the problem? And sometimes we'll assess someone and actually they're doing all right.
They're doing okay, yeah.
And you just say, actually, you're doing all right. And they just need to hear that.
Yeah.
I wish they were all like that. They're not like that, but yeah, some are. You do meet people who've had quite serious injuries who actually sleep really quite well, and it's probably because they always have done, and the bit of damage they've had sustained to their brain hasn't really impacted on the sleep control mechanisms too much.
Yeah, and we had a question actually, David, if you don't mind me asking it, because I think it's a good one. It's from Louise, and it says, would you recommend a sleep assessment before or after trying medication to aid sleep?
Oh, before. There's an awful lot of stuff that we can do to avoid the medication. And the things that we would focus on doing initially would be the psychological and behavioral things, which are non-toxic. And we're empowering people to then take control of that issue in their lives and manage it now and in the future. If you go down the medication route, you're not empowering the client, you're just dosing them every night for the rest of their lives, and that's quite disempowering. And a lot of people don't like that, because they don't like the hangover effects of the medication the next day. That inhibits on their ability to have energy to engage with OT and physio and remember what the solicitors asked them to do and all that. So the medication, we've got big issues with that. So we'd always want to go in, do a good assessment first, then we can try things, and we get good success rates without having to go to medication. We're looking at around 75–80%. So most people, we can do stuff to help, sometimes quickly, sometimes takes a bit longer, and then avoid that that dosing route, which is problematic to say the least.
Okay, and we're running out of time as normal, but I do want to ask you a wee bit about the kind of, you've touched on this already, but the most common kind of treatments there are for people. You've mentioned already, kind of looking at other things before medication. What are the most common ways that you tend to treat people who have corrupted sleep?
We use CBT, cognitive behavioral therapy for insomnia, CBTI, which is what that is all about. How we assess, treat, do it, and apply it to vulnerable groups of people, and with some tweaks for the vulnerable, for a brain injured population, we dial things down, do things more gently. But it's what the NHS recommend, what NICE guidelines since 2016 recommend CBTI as your treatment pathway of choice for managing a sleep problem. Tablets are number 2 on the list, and they're a poor number 2 as well. We definitely don't want to we want to do this CBTI stuff first.
Yeah.
And at the moment in the UK, it's only those 2 things that are validated and approved by NICE.
Okay.
So other stuff, it doesn't have efficacy, and we would say don't do that, especially with a medical legal case, because if you end up in court, some prosecution barrister is going to nail you to the wall for it.
Yeah, yeah, that's so interesting. And finally, and I'm going to put you on the spot a little bit here, David, but top tips. I love a top tips, my favorite thing. The top tips for people watching this webinar, rehab professionals who are dealing with somebody in a position where they're saying, I've got corrupted sleep. You know, what's the best thing for those people to be doing?
So CBT for insomnia essentially is just putting in all the things that sleep likes and getting rid of all the things that sleep doesn't like. So top tip, all the stuff sleep likes is a really good routine. Stick to it, and stick to it 24/7, 365. Sleep will really like that. Sleep also likes physical and mental activity and outdoor time for the melatonin that we get from the light pressure, and you get loads more light pressure outdoors than you do indoors. So spending time outdoors, being physically and mentally active, having a good routine, they're all the things that sleep like. So do that as much as possible. Yeah. And get rid of the obstacles. So anything that gets in the way, anything that makes you too physically or psychologically hot at bedtime is going to get in the way. So you need to wind down, get off the screens, don't exercise, hot baths, eat too much, drink too much, nicotine, alcohol, no fun stuff in the 2 hours before bed. So you
just lie quietly in your chair.
Any of that, and then wind down. With one exception to that is caffeine. If you're struggling with your sleep, leave caffeine alone after lunch, because it takes a long time for our bodies to wash that out. So that's getting rid of all the obstacles. If you do that, optimize good routine, outdoors, bright light, avoid the obstacles, nicotine, alcohol, eating, exercise, hot baths, screens, all that, you've got a 70+% chance of sorting the problem out. So it's try those things out first. And if you're still struggling, you might be in the 30% that needs a bit more help. You might have apnea. You might be more psychologically distressed, brain injury, all those extra factors we talked about earlier. So some people do need more help, but most people, 70+%, will benefit from those more straightforward, simple, non-toxic things.
Yeah, the hard bit is actually putting that into practice, though, David, because you say those things and then it comes to whatever time you think, oh, I'll just watch this and I'll, you know, just have a little hot chocolate or whatever. And it's hard, isn't it? But we are going to come back and do an episode aimed at professionals, busy professionals who are knackered, including me, feel knackered all the time, things that we can be looking at, that we can be doing. So we can dig
into that in a bit more detail at another time.
Perfect.
Today, I know we were just wanting to focus more on the client's issues, but
exactly,
to talk more about.
Well, thank you so much, David. That's so brilliantly helpful. And I'll make sure that everyone knows whenever we're going to come back. And because we've done all of these webinars kind of about serving the clients, which is how it should be. And we're going to do a self-serving episode for just us and how to improve our sleep and our lives. So I'll let everyone know about that. But thank you so much, David. It's been so helpful and so insightful, and really appreciate you coming on.
No, my pleasure. Thanks very much for inviting me. And I know it's been very brief today, and I think Holly is going to send around contact details for us. If people do have questions for us that they want to get some more information on, we can send that out to you if you want to get
absolutely. We'll make sure the recording will be available from tomorrow, and all of the contact details will be available. And sure, if anyone's in any doubt, you've all got my details, so drop me a line and I can pass any messages on to David. Okay, thank you so much for joining us, everyone. We'll see you next Wednesday, 1 o'clock, same time. Thank you.
Take care, everyone. Cheers.
Thanks, bye.
Bye.